Let's start the next session. We continue with our expert faculty. I told you we had experts from different fields, and the next speaker, Clare Allen, is a consultant radiologist here in London at UCL. And I've been talking to Clare before everyone sat down, and I know she's going to give us a very interesting and provocative way of looking at how we should be considering prostate cancer from the radiology perspective. Clare.
Thank you very much. I heard that people couldn't hear people at the back this morning. Is that, I've got a microphone on. If you can't hear me from the back, can you wave at me? I recognise some of you, so I apologise because some of you may have seen some of these slides before because I've done some clinical nurse specialist teaching. I'm going to talk a little bit about imaging, and I am aware of quite a lot about what I'm going to tell you is a little controversial, probably Chris would say very controversial, but I just wanted to give you a flavour of where I think imaging is going with prostate cancer. And one of the things, I apologise for walking around, but this is a very old lecture theatre and it was definitely designed for demonstration rather than lecturing to a very big board, so I'm going to wander around just a little bit. The prostate is really fascinating in terms of imaging, and you probably all don't know, but the prostate is almost like a fingerprint. Every man's prostate is entirely different, and we've got to the stage at UCH that actually sometimes we can put a name to a prostate. But I think therein also lies the challenge, because it's not for us like imaging a liver or a kidney or a lung, where there is no way of discriminating whose they are. And it's that difference between everybody that is a normal variant that makes prostate and identifying prostate cancer, I think, so challenging for us. And the other thing about the prostate is it is, to me, astounding that we do not image it more. If you consider every other urological cancer, if you have a patient who has a possibility of having bladder cancer, if they've got a possibility of having kidney cancer, what's the first thing that you do? You organise them a CT scan or an MR scan, and it is interesting, and we can maybe have a discussion later as to why it is that the prostate has been left there without imaging as one of the first modalities that we use. And what I hope to show you by the end of my lecture is that perhaps we should be using it as a first modality. And the other real problem that we have, and again it's one of the only things that we do this to, is that we use a chance biopsy in order to guide what our patient's treatment is going to be. It is a random biopsy of a spherical structure, and if you imagine taking an orange with pips in it, the pips being the cancer, and you've got the orange from the outside, and I said, find me the cancer, you can understand why it is that the prostate biopsy is just not a very good test. And what it does is it gives us a lot of insignificant cancers, which I'm sure Chris is going to talk about, and about 25% of prostate biopsies may give you an insignificant cancer. The other thing that it might do is it might not detect the big cancers that someone's got, and I'm going to talk about that in a minute. False negative rate of up to 30% for the prostate biopsy. And what does that do for your patient? Well, it gives them a wrong risk for what their prostate cancer is going to do. I thought the easiest way to show this is to show this slide, and if you can see that the red blobs are the cancer, and the black lines represent the transrectal prostate biopsy that comes in from the rectal wall into the prostate. And here's a patient with a tiny little bit of cancer that has been biopsied twice, so he thinks he's got maybe significant bilateral disease. This is a large tumour that only the edge of it has been biopsied, so again you might think he had a little bit of disease, but in fact has more. We have an anterior tumour, and we all know about anterior tumours not being biopsied at a normal transrectal biopsy set, which is a biopsy wall. And then we have a tumour that just falls between the random biopsies. I think it's quite a good illustration of the difficulties that we have. So what I thought we'd do to start with is just have a few patients. I'll tell you a little bit about the imaging, and then I'll come back to them and we'll see what we do with them. So this is a patient, pretty typical, that will come to see you in a clinic. Had a transrectal biopsy, low risk, wants to go on active surveillance. PSA of 9, stable over a year. Just think about what you might do, what you might suggest for him. The next one came to us for a second opinion. Lots of family history, two relatives, brother and father, PSA of 5, 2 negative biopsies. Had a routine MRI that was said to be normal. What would you do there? 52-year-old, raised PSA, unfortunately got measured without him being asked. But it was 7.6, so he came to see us in clinic and said, I really don't want you to biopsy my prostate. What would you do for him? And the patient who comes with low urinary tract symptoms, an elevated PSA, and a tiny amount of tumour on biopsy. What are you going to say to him? So let's talk a little bit about cancer imaging. What I'm not going to do today is talk much about staging. My interest predominantly is in the detection of prostate cancer and helping to risk stratify men in order to be able to make decisions about their prostate cancer. Staging is something that is a little controversial in that the NICE guidelines will only allow us to do MR staging once that patient has decided on radical treatment, and I'm sure most of you disagree with that guideline. But we're going to talk primarily about detection. And we're going to talk about the use of biopsy and the use of MRI. And also, if we've got time, talk a little bit about treatment and looking at different treatments other than radiotherapy and radical prostatectomy for prostate cancer. I'm sure you've all heard about the ablative treatments, which sort of sit between having no treatment or active surveillance, which Chris is going to talk about, and having radical treatments such as radical prostatectomy, radical radiotherapy. I'm also going to talk a little bit about recurrence if we have time. So where are we on the detection front? At the moment, what we are using predominantly is a raised PSA or abnormal DRE in order to deliver that man a biopsy. What we know about a transrectal biopsy is that it really doesn't give us accurate information about what is in the prostate. And that is because the biopsies are done to a standard plan. And this is the template, this is the 12-core template that we usually use transrectally, 6 cores from each side, spread out. It's a peripheral zone biopsy, and again, anything in the anterior gland is not sampled. There are some new work going on trying to make ultrasound more predictive, and some of you may have heard of prostate histoscanning, which is a relatively new technique, looking at the ultrasound image, putting it into a black box, they won't tell us quite what it does, and then putting a little bit of red stuff, if I can get this to work, there we are, putting a little bit of red on the ultrasound image as to where they think the tumour is. There was a great flurry of very positive vibes coming out of prostate histoscanning about 18 months ago. We're part of a group looking into whether or not this technique will be useful, and we still don't know. But obviously, if you had an ultrasound that you could use in clinic that put little red blobs on your grayscale image of the prostate as to where they thought the tumour was, which you could then target your biopsy, it would be a phenomenal achievement. But we're not there yet, and some of us are still a little sceptical that it will be as good as they predict it will be. So what have we done, because we know that transrectal biopsies aren't very good? Well, what we've done is we've increased the number of biopsies. We've said to men, we're not quite sure what's there, let's take some more samples. And one of the ways of doing that is to do a transperineal biopsy, in which you can actually take up to 50 or 60 samples of the prostate so that you can be more certain as to what you're dealing with. How many of you have transperineal biopsies available to you? Gosh, not all that many, maybe less, maybe about a quarter. And of course, one of the things about transperineal biopsy is a desire by certain clinicians to give that particular patient more certainty about what is in their prostate. It's done under a general anaesthetic, it's done through the perineum, so the risk of sepsis is much lower than it is for a transrectal biopsy, and the side effects, the bleeding side effects, are also much less as well. And you can see on the screen here there's a template put on the perineum. There are holes in the template, and you basically take a sample through every hole. So the bigger the prostate, the more samples that you take. And I thought I'd show you some of our data from UCH offering some of our patients, and these were particularly patients who wanted to have ablative treatments to their prostate rather than having a whole gland radical treatment. What we said to them was in order to be able to give them an ablative treatment, we needed to have much more of an idea what was in their prostate. So as well as having their transrectal biopsy, they also had a template biopsy. And you can see that the mean number of cores went up from 10 to 31. And the other thing that you can see, which is not surprising, is that the Gleason score went up from Gleason 6 in the majority up to about a third, going up to Gleason 3+4. So we upgraded them mostly, some were downgraded, but the other thing that was interesting is that some of the men who we thought had unilateral cancer, half of them actually on template had bilateral cancer, and as you know, cancer is a multifocal disease. And just to show you a few examples of what we found with our template biopsies, 73-year-old PSA 7, low volume, reasonably low Gleason score, and this patient was considering ablation or indeed active surveillance. He underwent 32 cores, half of which were positive. And you can see, this is just a grid showing you the urethra is put on the D row. You can almost see where his prostate would have been, so the right side, the left side, and you can see the colours of where he had all of his positive biopsies from. So in fact, he had widespread multifocal disease, and he wasn't suitable for any of our ablation programs. This is another patient who was thought to have PSA of 4, 67-year-old, low-grade, low-volume disease, and indeed his template showed exactly that. So this was one where the template and the prostate biopsy, the transrectal biopsy, were the same. And here's one very interesting where you can see the pattern of tumour is predominantly in the anterior part of the prostate. He, as you might imagine on a transrectal biopsy, had a very low amount of tumour, and of course he had much more and a higher Gleason score once we were able to sample that anterior gland. And these are the patients who think they have low-risk disease, but in fact, perhaps, and Chris will obviously address this, may not. So what we decided to do was to see if we could stop having to have all these large number of biopsies and all these second and third biopsies, to see if we could use imaging to try and predict and to try and localise where men had their prostate cancer. And we've been doing this now at UCH since 2005. So for 5 years now we've been running a programme using MRI to try and identify and localise cancer within the prostate. So this is separate from staging. This is definitely to try and detect the tumours. And these are the reasons why we were doing it. We want to try and reduce the number of biopsies. Perhaps in some men, say to them they don't need a biopsy at all. We wanted to target them so that we got the highest Gleason score. You all know that when patients go for their radical prostatectomies, you know, the surgeons in the room say, aha, I've done this patient a great service because you only had Gleason 3+3, but I've found large amounts of 4+3 that you didn't know about. And therefore I've done this patient a great service. We've all got problems with patients with negative biopsies and rising PSAs, and it's very difficult to know how to counsel them and to know what to do. And indeed, what we're looking at UCH, and what you've probably heard about, is some of the ablative treatments which sit between having no treatment and having radical treatment. How many of you have access to cryotherapy? Cryotherapy? Goodness. HIFU?
Well, we do in the cancer centres.
Yes,
but not
yes.
From the
No,
district
but in your cancer centres, but yeah. So what we've done is we've used MRI in a slightly different way, and we've used it in a way that actually is not particularly difficult. If you have your lymphoma scanned, if you have your kidney tumour scanned, we use exactly the same parameters, MRI parameters, to look at those tumours as we do for the prostate. All that we've done is that we've used all of what we've learned for other cancers and we've started to use it for the prostate. But what we need to do is we need to do lots of different sequences. We need to look at all of the different aspects of the tumour biology. This is quite a busy scan, but it just shows you the 4 different ways that we can look at the prostate. The traditional way, and what you get for staging, is just a T2. And that shows you the tumours, and I'm going to show you some pictures in a minute. But what we do know is that biopsy affects the T2 hugely. And what you probably all have in your MDTs, if you sit at MDTs, but you hear the surgeons particularly say, I'm not interested in getting an MRI, it's not going to show me anything, it's full of biopsy artifact, and indeed it can be in certain patients very dangerous, because if we MRI immediately after a biopsy, we often overcall because we actually can't see where these tumours are, and we often overstage people and we deny them radical treatment. So I think, from our point of view, we have to be very careful when we do that. So what we use are these parameters. We use diffusion weighted, and what that is it's a technique that looks at how tightly cells are packed. That's all it's doing. Tumours have tightly packed cells. And so if you've got a lymphoma, if you've got a renal tumour, if you've got some lung tumours, the cells are tightly packed. It's just a technique for looking at cell packing. And how it does that is it looks at the way that water moves. And it's very clever. And what you get is a base image where the areas of tightly packing are white, and you get what we call a map where the areas of tight packing are black. And so it's really easy. You look for white blobs and black blobs, and it really is as straightforward as that. The other thing that we do, which is just the same as any other tumours, is we need to give contrast. Now, I'm sure that the majority of your scanning centres do not give contrast. If you sent someone for a kidney scan, you would expect to have an enhanced study, a triple phase study indeed. For all tumours, you'd expect to give contrast, and the prostate is no different. Tumours have abnormal blood vessels associated with them. They have to have them in order to grow. And what contrast does is it shows up the abnormal permeability around these blood vessels. You all know that tumours enhance, prostate tumours enhance as well. What's interesting about these 2 different parameters is it may be that they give us some grade information by the amount of packing and the amount of enhancement may be associated with higher grade tumour. So we are looking very carefully now at seeing whether or not MRI can not only detect but also grade tumour. The last thing is spectroscopy, and we don't do a lot of spectroscopy in the UK. It's something that the Americans started, and I think, if I was being honest, I think it's one of the things that's put MRI prostate back 10 years, because it's a difficult technique to do. The Americans said you had to use an endorectal coil, which was uncomfortable. That's actually something being put into the patient's rectum in order to scan them. Everybody went, oh, I don't think we're going to do that. And so we ended up not doing anything. And I think for us, it put us back many years. And spectroscopy looks at the metabolites in cells. It's a difficult technique. And in fact, I don't think is as good at picking up tumour as the others. But perhaps it will also give us some grade information. So let's look at some pictures. This is the T2 weighted of a prostate. This is the patient's bladder. This is the rectum. And these are axial scans from the base of the prostate here, where you've got the seminal vesicles. There's prostate, and coming through to the apex, and that's the sphincter. The prostate, as I said before, is different in everybody. The bit that really is different is this, the transition zone, central zone, because that grows. When a man is 20 years old, it's almost non-existent. And as they get older, that just grows. And the rate of growth and what it looks like is different in every single man. And that's partly one of the difficulties that we have in looking at some of these images. And the peripheral zones are predominantly high signal or white. And when we're looking for tumours, we see them as black blobs. And if it was always this easy, we wouldn't be having this lecture because we would all be doing it. But tumour we see as black areas or low signal areas on the T2, and you can see a much smaller, more discrete tumour here sitting on the left side towards the gland apex. And you can see here at the base of a prostate, a diffuse area and another there. Now, one of the difficulties is that not all of these areas are tumour, and that's why we can't just rely on the T2. We need to use the other parameters. In some patients, these areas of low signal can be inflammation, in some patients they can be atrophy, and in some patients they can be a granulomatous prostatitis. So although all tumours will look like this, not all of these are tumour, which is what makes MRI challenging. So let's have a little look at multiparametric MRI, because that's what it's called when we do all these sequences. Here's a tumour sitting in the right peripheral zone, and you can see on the coronal view, so this is the bladder here, base of prostate, apex of prostate, here's the tumour. When we give the gadolinium, you can see, that's the contrast agent that we use for MRI, you can see focal enhancement, which corresponds with the abnormality on the T2. The transition zone also enhances because that's new tissue as well. And one of the challenges for us is identifying tumour enhancement versus enhancement that's there because of the new transition zone adenomas. And here's one of my white blobs. And this is where diffusion is so wonderful because it shows us where the cells are tightly packed and it gives us a lovely little white blob which makes it very easy for us. So not much skill with these ones. So we get a little white blob, which is where the cells are densely packed. So this abnormality has all of the things positive. And what you can then do for other patients is you have the T2, the ADC, the diffusion map, and the enhancement, and you can see areas of abnormality, and you can see the matching on all of the three modalities. And that makes it very predictive, and I'll show you how predictive in a minute, that this patient has got tumour. And here's a much more discrete lesion sitting in the right peripheral zone, and again, here's your T2, here's your contrast, and there's the black blob on your diffusion map. And you can see how discrete some of these tumours are, and you can then see why some urologists feel, why should you treat the entire prostate when you've got a little tumour sitting on one corner of it? One of the areas that we've been discussing is the anterior prostate, and MRI is very good at identifying anterior disease. And this is a patient who had a negative biopsy, but with a raised PSA. He was also on warfarin with heart valves. We saw a large abnormality in the anterior gland, well away from the areas that would be sampled. And we just took 2 targeted cores just through that. And we had 100% cancer core length on both of those biopsies. So for certain patients, it makes it much more straightforward for them to be biopsied. And here's another patient whose biopsy was negative, and again we could see a discrete tumour sitting in the anterior horn of the peripheral zone. Here's the T2, here's the diffusion, and again he was templated in order to demonstrate where that tumour was. I'm not going to talk about spectroscopy because we really don't use it, and it's a difficult technique, and I'm not convinced that it's the way that we should go in the general patient population and should just be a research tool. Is there good information about what I've told you? And what I can tell you is using multiparametric MRI has suddenly just exploded, particularly in Europe, in France, in Belgium, in Holland, and now even the Americans are starting to do it. We were at a conference in New York at earlier this year, and all of the American centres are now going to start doing multiparametric MRI for their patients. And this is data from the group in Lille, from Arnaud Villiers' group, and they looked at the way that multiparametric MRI can identify tumour. And I'm going to come and talk to you a little bit about tumour volume in a minute when we talk about what you can anticipate from radiologists in terms of MR. And interestingly, just recently there's been a paper written showing that the discordance between the biopsy results and radical prostatectomy specimens is much narrower if you use MR guidance in order to identify where your tumours are, so that these patients do not have a higher grade and a higher volume on their transrectal, on their radical prostatectomy samples. So let's go back to our patients and see what we were doing, having shown you all of those. Obviously the answer in all cases would be an MRI, otherwise I wouldn't be showing them to you. And we are lucky in our institution in that we do have the ability to offer all these patients MRI. So this patient, with his 4 millimetres of Gleason 3+3, low volume, low risk disease, I think most people would have put on an active surveillance programme. It is our policy, and Chris will tell you what his policy is to offer a multi-parametric MRI to all patients prior to being put on an active surveillance programme in order to make sure that a large anterior tumour hasn't been missed. And this was his prostate, and this is his T2, and we could just about identify on the T2 this large homogeneous area of low signal, which is indeed his tumour, and this was his diffusion, his black blob if you like, and this was his homogeneous enhancement. And he went on to have a template which showed Gleason 3+4, and all of these caused 9 millimetre cancer core length, 8 millimetre cancer core length. So in fact, he actually had relatively high burden disease. 9 out of 28 caused positive Gleason 3+4. He decided to have his prostate out, having been shown the images, and our 2.5 mils of tumour on his radical prostatectomy, and he's currently got a very low PSA. Let's go to our positive family history. I think Chris will identify this. I'm sorry, I'm not stealing your thunder, I hope. But I think family history is a really positive predictor for some of these men, particularly if they've got 2 first-order relatives. And this patient had a brother and a father, both of whom had prostate cancer. And he came to us from from Cambridge, 2 biopsies negative. His standard MRI, done without multi-parametric sequences, was normal. But he was very persistent, and if you look at his PSA, you can see why he was worried. A steadily increasing PSA. So we did an MRI on him, and these were the sequences through the midgland, which looked entirely normal. But what we saw right up, sitting underneath the base of the bladder, was this large homogeneous area, approximately 2 mils, which showed homogeneous enhancement with gadolinium, and it's a black blob on the ADC map. And we biopsied that, and indeed he did have a large tumour sitting in an almost inaccessible place to a transrectal biopsy needle, unless you knew that you had to target it there. And he went on to have a radical prostatectomy. And now we come to our poor man who got his PSA without being asked, without being appropriately counselled. And what we said is, have a scan. Let's see if we can see if there's anything there. You're laughing now. And what we showed on his scan is we were able to show him his tumour. And not only that, we were able to show that he actually had a large amount of tumour abutting the capsule of his prostate, and that he actually had early T3 disease. You can see it sitting here towards the base of the gland, and this was the enhancement. He had enhancement all the way along the capsule, and he actually had quite a large volume of tumour in a relatively small prostate. Having seen that, he decided to go on and have the biopsy, and he also ended up with a radical prostatectomy, and T3A was confirmed. So for him, we were able to give him a little bit of extra certainty that what he was planning on doing or not doing was the right thing or not. And just one more. This is a patient with a little bit of disease, but a relatively high PSA. And what we did for him was a multi-parametric MRI, and what we showed him was that he actually had a big prostate. He had a 100 mil prostate. His PSA density was actually very low. We couldn't see a tumour within his prostate, and he has remained on PSA surveillance. He's gone into an active surveillance programme, but happy that we haven't actually missed anything significant within his prostate. So why aren't we all doing it? Why is it difficult to get MRIs of the prostate? My personal view is that we've had a really bad track record. We've done MRIs after somebody's stuck 12 needles into a prostate, and we've thought that that is going to give us an image that we're going to be able to look at and make any head or tail of at all. And of course we can't. And that has led us to a very low predictive value of cancer and a very poor staging track record as well. We've got poor reference standards. The only reference standard we have is a radical prostatectomy sample until template biopsies came along. We didn't know whether we were right or wrong unless the patient had their prostate removed. Well, a lot of men, as you know, don't want their prostate removed. And we need to be able to find a non-invasive way of telling them what is in their prostate without having to have it out, in my view. One of the problems also is the health economics. How many of you can get prostate MRs very easily? My feeling to that is, in our institution, we've costed our MRI prostate and it's £200. That is cheaper than a biopsy, it's certainly cheaper than a second biopsy. It's certainly cheaper than an episode of sepsis. It's also cheaper than quite a lot of the treatments that that patient may not need. Also, I don't see why if you've got knee pain or back pain you can have an MRI, but if you've got a raised PSA you can't. It doesn't really seem to be a sensible way of going around things. Just to show you what biopsy does, this is a prostate before biopsy, this is a T1 and that's a T2, and you can see these beautiful peripheral zones where you should be able to see tumour. And 2 weeks after biopsy it goes black, because that's what blood looks like, and that means you can't see tumours. It also makes the capsule go shaggy, and it also enhances because it's healing. And so you can't tell what's happening. And even after 4 months, the prostate hasn't gone back to normal. At the moment, we're just finishing a trial. We've recruited 14 patients who've all agreed with ethics review to have 6 prostate MRs done so that we can study the effect of biopsy on these parameters. Hopefully by probably the early part of next year, we'll be able to get that data out and we'll know for certain, rather than anecdotal data like this, exactly what biopsy does. But what we do know is that if you can see a tumour before biopsy, at 2 weeks you won't be able to see it. Probably at 2 months you won't be able to see it. And possibly only at 6 months will you start to see it again. So the key, the real key, is to do these MRIs first. So what do we need in order to be able to accept it? I think we need these things. As radiologists, we need you to agree that we are not going to be able to see all the cancers. And that is crucial. We know prostate cancer is multifocal, but we know that quite a lot of the small foci may not need treating. There is no way that we are going to be able to see 1 or 2 millimetres of Gleason 3+3 disease. But that may be a good thing, because perhaps we don't want to see that. So what we need to know is, where is the boundary between what we can see and what we can't see? And is that boundary safe for those patients to be able to tell them whether they've got tumour that needs to be treated or not to be treated? So we need to have an agreement. What is significant tumour? And what can we miss and what can we not miss? Radiologists need to get together, we need to agree how to do prostate MRI, and we need to standardise our reporting systems. I'll just briefly go through this because I've got some slides at the end that I want to get through before you've got some questions. We've been looking at our ability to do what I've just said to you, how good we are at identifying tumour. And we looked at 65 men at UCH. They had a template biopsy, which is the best that we can do, apart from taking their prostates out. We have a traffic light system for what we think is significant and non-significant disease. Now you can quibble with this, but we've got to set the things somewhere. So this is the system we use. Green being green, obviously, red being bad disease, and obviously there's going to be in the middle, which is the yellow. And so we score to this traffic light system. And so we were not surprised. These are our reporting curves, and this is 2. I've just actually got mine on there, but we haven't actually got the curves to show you. And this is all cancer. And we're not terribly good at finding all cancers, which is great. We don't want to be. But as we try and put the definitions of what constitutes significant cancer, our curves get better and better And what we noticed is that we actually have a very high negative predictive value for significant cancer. So that means what we've been looking at is, can we do an MRI and tell you that you don't need a biopsy? So we put this to the test, and we've been doing MRIs pre-biopsy for years, for 5 years. And we looked at the last 356 patients who came to have an MRI, and we looked at the ones that we scored negative. And interestingly, out of the 84, so that's a quarter that we said we couldn't see a significant tumour, half of those decided they actually didn't want to have a biopsy, and they believed us. They're obviously being surveyed, we haven't lost them, this is all part of a trial, but nevertheless, these men decided that on the basis of their MRI, half of them decided they did not want to have a biopsy. Of the half that went on to have a biopsy, we missed 2, what we might call significant disease. I think 1 millimetre of 3+4 we're never going to see, and whether or not that matters is for Chris to tell us. This one, the 6 millimetres of 3+4, was an observational error. We could see that, but we missed it. So that's a learning curve for us. So what have we done? Well, we've gone the next step, which is interesting for you, because our nurses now at UCH, our clinical nurse practitioners, now lead a one-stop prostate clinic, which has MRI as the first thing that the patient has done. And we've started this in January this year. And what happens is we get the GP letter saying, I think this patient may have prostate cancer. And what happens, within 12 days, they get an MRI. And they're all done on a Monday morning. At Monday lunchtime, the whole team sits down and we look at the MRI. And it's reported by 2 radiologists, and we decide what it shows. That afternoon, they're seen by the clinical nurse specialists. They're obviously at that meeting so that they've been fully aware of the discussion that's occurred. And that patient is told what their MRI looks like, and they're given an option as to what to do. And you can see the results. 8 of them had metastatic disease that we could see on their MRI. They were started immediately on anti-androgens, and we did a very limited biopsy of just the tumour. And all of those biopsies were positive, and that was to allow them to enter studies in the future if they needed them to confirm the diagnosis. 2 of them had anterior disease, so we didn't even bother to do a transrectal biopsy. They just went straight through that process, and they went straight on to have a template because their tumour was in the anterior gland. All of the others had targeted transrectal biopsies, and we're just working out how many of those were positive and negative. That will be published. I think Bowes Oncology is where this data is going to be presented, and that's next month. Interestingly, 12 of them had a negative MRI, and they were offered standard of care, which would be a transrectal biopsy, and all of them said no. And they've elected to go on PSA surveillance. And again, that's a group that we're going to be looking at. Very briefly, 2 minutes. Where do we go from here? We as radiologists have met up. We've met up with our colleagues from France, from the Netherlands, and from Belgium. And we have agreed, we met up in December 2009, we agreed a scoring system for the prostate so that we are all using the same way of telling people whether or not we think there's prostate cancer there or not. And we're using a 27-zone scheme. This is the prostate. It's split up into 27 zones. What we're then doing is that we are scoring for the presence or absence of tumour, so each zone. And what that looks like, this is one that I draw, and it's not electronic yet, but you can see what we do. PSA 3.1 to 3.7, family history of prostate cancer. He's got a tumour positive on T2, dynamic contrast and diffusion. 0.3 mil, probable tumour, right anterior gland. And we score it, and that scores a 4, so 4 plus, probable tumour. And this is his MRI with his tumour sitting up, right up the top there, which would not be accessible to a transrectal biopsy. And these patients would go straight to have a template. What we've also persuaded our pathologists to do is to do exactly the same thing. And this is a patient who's got the tumour that you can see on his MRI there. And our pathologists are now scoring to a traffic light system, and they're also scoring to a template so that we can give the patient the picture of his prostate, We can give the patient the picture of his biopsies if he's had them, and we hope that that will allow them to have more control over the treatments that they choose for their disease. We are just about to start, together with Chris Parker and Marsden, a large multi-centre study to look at this exact thing that I've just been talking about. And it's the ability of MRI to predict tumour within the prostate. All the men are going to have transrectal and transperineal biopsies. We're having 5 or 6 radiologists scoring. The Marsden's part of the group, Brighton, Bristol, various places, and we're going to try and do this over the next year, and we're going to start recruiting soon. My final slide. I think it's going to become the key element in the diagnostic pathway, and I hope I've provided some evidence to you of the efficacy of it. So instead of this approach to prostate cancer, perhaps we ought to be doing this. Thank you very much.
Well, I think we promised you new directions. Certainly Claire's given us one there. One of the biggest messages I've taken from that, Claire, and it's something that I believe, is that once you've had a prostate biopsy, MRI becomes uninterpretable in terms of local staging. So you've moved to a system where people are seen within 2 weeks of referral for an MRI scan. A completely new standard of practice, I suspect, for anyone in the room, and you make a persuasive case. Comments or questions from the floor? Yes, please. Tell us who you are. Is the microphone coming?
I'm Jackie Thompson. I work at Northern Cheshire Hospital. I'm just interested in the template biopsies. There's a Harrow Heart Hospital we refer into the template biopsies. Yeah. We often have the conundrum of our local MDT and have a discussion against MDT when patients' prostates are too large and greater than 60 mils, and they're often then put on a ditasteride and then seen in the clinic, but their anxiety inevitably shoots through the roof. What do you do?
Well, we MR them. I mean, we have a huge group of very large prostates and whose PSA density is actually very low. And I think in those cases, we survey them with MR, and we have a whole cohort of patients who they have a yearly MRI. Just like if you had any other tumour you would have, or potential, you would have a technique to look at patients at a time, and we MR them. And in fact, we're just doing a study with dutasteride and looking at retest, and whether or not MRI changes, and whether or not we can use, whether or not it's stable enough, and we think it is as a technique, to be able to look at a patient over years. And we've got patients now going back 5 years. And in patients who haven't had tumours or who've had little small tumours, you can see no detectable change. I mean, it is really quite extraordinary. And then in some tumours, you can see them growing. And it's just the most extraordinary thing to see, because we haven't actually seen many MRs showing tumours growing. It's a good group.
I think one of the interesting things about a meeting like this is to refer it back to what you do back at base. When you're in your MDT, how familiar is this story to you? Probably not at all. But I suspect we do agonise about, do we do MRI scans to stage cancer? And the message that you've given us is question that, because the role of the biopsy is crucial. And one other thing I think you've perhaps underplayed, Claire, is the complications that come along with template biopsies. Okay, sepsis is minimal, but retention rates are high.
They're high. Well, I totally agree with you, and that's why on that slide I said, what is the role of MRI? And I think partly it's actually to reduce the number. I mean, I think at the present time, the only way that people will say, I know what's in that prostate, is by taking 70 or 80 cores. What we hope to be able to do is to say, actually, you don't need to take so many. We can tell you the bits that we're unhappy about, and we can tell you the bits where we think there's definite tumour. And I think part of this is we have to try and reduce the number of biopsies these men have. And particularly transrectal biopsies, I think it's not a nice thing for them to have to do. The transrectal sepsis rate is going up, and it is not, it is not something that you can just say, I'll have one every year. I think it's getting to the point where men aren't going to put up with that, and we have to have a different way of trying to deal with these tumours.
Okay, so a big message for us to take back to our own hospitals. Any final questions for Claire? Yes, Jen.
Sorry, on a practical basis, how do you have the resources to cope with the increased number of MRIs that you're doing?
Of course they do.
Well, I think it was amazing, actually, I have to say, what happened to me. In 2005, when we started to do this, I was given 2 slots a week. The Euro list for the whole of urology were 2 scans a week, because the scanner was chock-a-block with backs, knees, and all other and sundry of musculoskeletal. And then the government decided that cancer should be a target. And then overnight, all of those musculoskeletal lists were wiped out. And I managed to persuade one of my senior clinical colleagues to start writing probable prostate cancer and to send them for an MRI. And because it had cancer on the form, it got in above it before all of things. So now we just, I mean, we're very lucky. At UCH we have 3 MRs, we've got 2 more going in, we've got a PET MR going in. So we do have a lot of space, but nevertheless, I think, you know, in terms of priorities, I think, you know, and if you look at the costing, I mean, our MRIs are £200. I think that's a good deal. And if it gives you more certainty about what's in that prostate, and if it gives the man a picture, so he can see where his cancer is, and he can say, oh, I can see it sitting there, or I can see it sitting there, or I can see it's growing. The other day I had a man who came who'd never had a biopsy. He's watched his PSA go like this, and his MRI had shown a little tumour in the base of his prostate, and over the years, over 5 years, it had grown. And he'd come this year and he said, okay, I'm going to have it biopsied. And I just took some limited cause through that. They all came back positive. And he said, you know, and it gives him some control. And I think, you know, that's, you wouldn't do a kidney, you wouldn't remove a kidney tumour without having a picture of it. And I don't understand why for prostates it should be so different.
Your point is incredibly well made, but I think if we were persuaded by the evidence that this was the right way forward, we should be examining who gets MRI with the resources we have and stop all the chronic joint pains.
The difficulty is radiologists to be willing to look at them, and there is a training issue, and we are addressing that.
Question up there. Who are you?
My name is Lucy Powell. I work at Colchester Hospital.
Colchester.
Trust. Just a couple of points. Just wanted to check. You were talking about it's a nurse-led clinic that runs. So the nurse sees the patient on Monday morning.
On Monday
sorry,
afternoon.
the MRIs are
Yes.
done in the morning, and the patient's MRIs discussed at lunch, and then Monday afternoon, CNS sees them, lets them know the result. 2 questions. First question is, do you find that you're having less problems now with breaches? Because obviously we wait 6 weeks.
Yes, we have no breaches.
Biopsy,
the reason this
and
was,
they all breach.
Yeah, they don't breach.
So that helps in that side of things as well, doesn't it?
Bank holidays don't occur in London. Bank holidays.
Yeah, this is a good day.
We do Saturday scanning.
And the other thing is how long does your wait from when the CNS explains to the patient and they accept to have a tussin biopsy? Is it the CNS that's doing the biopsy? Is it done that day? Or how long does your wait from then till the biopsy?
Because all the biopsies are targeted, because we look at the MRIs and they're all done by us. So the radiologists who report the
targeted from then on.
we do them all targeted. They have a normal set and they have targeted as well to make sure that we've encompassed everything that looks abnormal in their prostate, and it's done by us so that we can look at the MRI and do the biopsy. And there are slots available. We leave them that week to think about it, and the following Monday they have their biopsies. So it's Monday is the day. So the lot that we've seen the previous week come and have their biopsies the Monday the next week, and it just means that everybody's in the right place.
So, sorry to be clear, it's not a normal tussin biopsy, it's always a...
No, it's a normal tussin biopsy, unless...
and
yes, and a target
as well.
Yeah.
Okay, thank you.
Okay, the method. Sorry, yes, one final question. We must move on then. Who are you?
My name's Mary, and I'm a HC nurse at St George's Hospital. Just touching on the breach situation, if you see a tumour on the MRI that's done on that Monday morning, does that mean that the day from a cancer diagnosis is that day, or is that waiting then to biopsy?
How do you manipulate the figures in London? It's a great question, isn't it?
Great question. Don't know the answer.
We play the game, there has to be histological confirmation, and I'm sure that's the one that's safer to play. Now, the message this morning is risk stratification. I think we've heard that from both our speakers, and I can't think